There we go. So, okay, well, welcome everybody. I'm really excited to have this special interview with Dr. Lacey Venanzi. And I'll maybe do a very quick intro, and maybe you can also introduce yourself afterwards. But Dr. Lacey is the owner and practitioner at the Awaken Wellness clinic or practice in Reno, Nevada. And Dr. Lacy has been involved in the CIRS community, I believe, for quite some time. I know you're very well connected with several of the shoemaker doctors, including Dr. Eric Dorninger. And you've been, since we start meeting, we're getting to know each other. I know you had a very high interest in creating sort of a research program focused on understanding how SIRS impacts the digestive system. I know that's like a big area of interest and more importantly, how to restore it, right? And this is an area of emphasis in your practice, treating patients with a lot of gut issues. And today, my hope is that we get to talk a little bit about this, explore some of the things that you do and some of the things that you know in that area. And we can also certainly open the conversation to other intersecting points. So yeah, thank you so much, Dr. Lacy. And as a maybe bit of background, it would be great for you to introduce yourself.
Yeah, absolutely. Thanks, Christian. So yeah, I'm a chiropractor by trade. I actually before that was an opera singer, so I've had a colorful background. But I studied chiropractic medicine, and I always thought going to chiropractic school meant that you were going to study more naturopathic primary care. So I didn't get that in my program, unfortunately. So then consequently, wanted to study functional medicine outside of that. And that's really when I just got to meet some really cool people that took me under their wing. Namely Jatis Karazian. I worked for Apex for a long time and got to learn with him and a lot about autoimmunity. And that's also where I met Dr. Dorninger, who's, a big face in the SIRS community. So those were my two mentors. And I didn't really understand how lucky I was at the time that I was learning from them. But they really just set me up to just have good foundations in diagnosis, I think. But for me, I think as practitioners, we're so guided by our own struggles. And I really felt that the microbiome was missing from what I was getting, both from them and even from my own education. So I found another doctor out of New Zealand named Jason Harlech. He's a naturopathic doctor out there, but he really specializes in the microbiome. And he really was at the forefront of a lot of prebiotic research. So I got to study with him, and that really, I think, changed my outlook on practice completely. Much more of a holistic outlook, but really with the gut as the center, and this whole theory behind ecosystem theories of looking at the body as kind of like a garden and making these tweaks and changes to things. And it really resonated with my soul, and it really resonated with how I was treating patients and what worked with them. It felt really different and exciting. So I kind of landed there for a while. I really practiced sort of traditional primary care with an emphasis in the microbiome. And that's the people that sought me out were very much those types of patients. And then I, got hit with SIRS personally. We moved into a home that we were gonna redo, as a lot of us, I think, had those hopes and dreams, and it killed me. So it was one of those homes, those horror stories where, within 2 months I was pretty much bedridden. So that's really what brought me into SIRS medicine. And I was lucky enough that I had a mentor like Dr. Dorninger that recognized that I had SIRS right away. And then, pulled me in. It was like, well, sort of divine intervention. You got to do this in your practice now. So that was almost 5 years ago that happened. And that so was a bit of a different layer for me to welcome in chronic illness. I feel like SIRS is so much to do with chronic illness. But it was sort of the perfect marriage of what I was already doing with the gut. And so that's me doing the Shoemaker protocol has always had so much foundation in microbiology with the gastrointestinal tract. So yeah, my treatment's a bit of a hybrid because of that background.
I see. I'm curious about I don't know if you're willing to share a little bit about your journey as a patient and what that looked like in terms of, maybe what kinds of, if you were able to pinpoint, were you someone who was dealing with just mold, or was there also an endotoxin, actinobacteria, and maybe what did your treatment look like as a patient? I think it's always very empowering for patients to hear these stories from practitioners and to see what it looks like to kind of be on the other side of completing this protocol and these treatment regimens and have functionality back.
Absolutely. It's funny, and I think a lot of patients relate to this. I had a SIRS breaking point, I call it, which was when I moved into that home. But I've been struggling with SIRS my whole life, right? It's just been diagnosed as other things, whether it was celiac disease or ADHD or, chronic rashes, frequent urination. I've been dealing with some level of that my whole life. But it wasn't until that home, which now thinking about it, and I think we all develop these different spidey senses for the toxins that try to kill us, but that home had mold for sure. But the primary offender was endotoxins, definitely. And I call myself an MMP9 SIRS patient because my MMP9 was at 2600 when I was at the peak of my SIRS decline. And for people that aren't familiar with that, really under 400 is ideal. And it's funny in psychiatry, when you're above certain levels, they can almost guarantee certain psychological disorders for you. It's more based off traumatic brain injury, but I've pulled that into SIRS practice. So over 1,000 guaranteed suicidal ideation. And that was really a huge part that I was struggling with. It felt like I was losing my mind, like I was unraveling from reality. And my father is a PhD psychologist, so I had an advantage in that. Like he knew me, he knew my story, and he thought I had a brain tumor. Like he was convinced with how I was reacting, and I was just begging to be institutionalized because I had no control over myself anymore. But what happened for me was that I knew I was being poisoned. So I had that silver lining of knowing that it wasn't my psychology, which so many of us don't have that comfort. So I really held on to that, and cholestyramine very much saved my life, right? So when I finally got up the courage to start cholestyramine, because I was afraid it was going to make me worse, and my husband looked at me and said, what's worse than this, being institutionalized. So I, totally rock star took like 8 capsules at once when I finally was like, I'm gonna do it. But I felt like a demon was exercised for my brain. Like it was just the craziest experience for me. So I very quickly was pulled out of the darkness from cholestyramine. Like I tell people, I went from like 20% to about 60%, which felt like such a gift for me. And then when I finally moved out of my home, I got another 10, 15%, but my biome was really wrecked from that exposure. Breathing in endotoxins oftentimes inoculates the microbiome with lots of different infection. I had really high levels of Klebsiella, which is one of those that you're going to inhale a lot from septic tanks, which is what was happening with me. So then began sort of my peeling away those layers of that ecosystem again. And I would say that, gosh, that was like a 2-year journey of really figuring out, tweaking the levels of my microbiome. And what was fascinating about that is really finding these interactions, these cross-species interactions in the microbiome, because I was so
Mhm.
familiar with SIBO,
Mhm.
not really familiar with SIFO. And so it really threw me into some of those connections and digging into that. And then I will say for me, the cherry on top in my treatment was really doing peptides. Peptides made me feel normal again. They gave me a resilience that I didn't have before then.
What peptides, if you don't mind me?
Yeah, no, totally. So, Thymosin Alpha-1, I did Thymosin Alpha-1 and KPV, those two. And I've dabbled in a few others, but that moment I'm talking about was really Thymosin Alpha-1 and KPV for me. But I think with all people struggling with chronic illness, there's so many layers. I mean, I'm still uncovering layers, it feels like, with airway things that I'm now treating, and different ENT type infections that show up and understanding that, as well as just, psychological retraining, limbic retraining, what that means, beliefs that I hold in my body, fears that I hold in my body from that experience. And that too, I would say I'm in that phase now. And again, it makes me feel more and more like I can exist as a normal person again. So
Yeah. Yeah. I think that's really important, and I'm starting to exploit some of that now on my end. And I think for me, part of that is rebuilding a social life, which I started doing here in Santa Fe. And I think those things are really important. I agree. And certainly, the way I think about it is your the Shoemaker protocol is very geared towards building the physiologies to allow you to then exploit these other things that have to do with, anything psychosomatic or emotional or psychological, anything in that sort of domain. It doesn't mean that I guess people can't do it before. I just personally have found more utility now that I feel like my physiology is starting to normalize a little bit more. And it sounds like you're kind of in a similar path in that regard.
you froze, Christian. I lost you here for a second.
Oh, am I still? Just let me know. I can still hear you fine. Like I don't have any issues. Oh, now she's okay.
Oh, there we
There we
go.
go. There we go. Yep, you were there all along. So I think you kind of got the gist of what I said about, working for me, working towards the end on the emotional, psychological aspect has been important, but I feel like for me, trying to get to a certain level with the physiology has been really important. Going back to, yeah, going back to the peptides, what is your take on the modality? And so we've talked a lot about KPV here. I take KPV, but I take it as an oral in an oral version. And I haven't taken thymosin alpha or thymogen, which is sort of an analog. Do you have any thoughts on the sort of modality of these peptides and their effectiveness?
Do you mean in terms of like how you're getting it into your
Yeah,
body?
how you're consuming it. Yes.
I have not seen a lot of success with oral peptides. I will say I'm a bit biased because I really do push for injections with people initially if they can afford it, because I just see such a profound difference with the injection versus the oral peptide. Now, from a research perspective, taking things orally, if you do have intestinal permeability, there can be an advantage in that way in terms of like a KPV or BPC 157. BPC 157, I've seen have some paradoxical reactions for people who've taken orally where it's literally caused intestinal permeability. So I think that there's a mechanism there that we don't quite fully understand yet. And then I just think people really need to practice informed consent with recommending those things for people. But to me, thymosin alpha-1 is if I'm on a desert island peptide, right? To me, it's the safest. It's used in children. It's been used in autoimmune research for over 50 years in Europe. There's so much clinical data that we have on it. Really the mechanism is I tell people it's giving you a third immune system because it's really bringing your thymus gland back, right? Which involutes around 8, 9 years old. So obviously in SIRS, we've lost normal functioning of our immune system. And so to give yourself something that's like 10,000 soldiers that you desperately need, it's just been so profound for me and for so many of my patients. I will say the only negative thing I've noticed for some people is if you are a co-infection person, those 10,000 soldiers are going to work.
Yeah. The, I think we may have temporarily frozen again. Let's wait for another second. I think we'll come back. Oh, I think there we go.
I'm gonna shuffle over to this other side of my
This
office.
other side, that's okay.
You guys get to see my really cool open space up here that we just
Oh, it
got.
looks like a very source friendly space.
It is very search friendly, and I'm really wanting to host movement classes. I taught Pilates for 12 years, and I just think movement's so important to healing. So, anyways, we got this cool space, but I'm hoping being in this corner will be more
Yeah,
advantageous.
yeah.
Cool.
Quick question. What was the peptide you were referring to now that's has safety for children?
Yeah, thymosin alpha-1. Now I will say,
Oh, thymosin alpha-1. Okay.
yeah,
Yeah.
thymosin alpha-1, and it depends on the age because some people theorize it can affect growth plates. So we want to ideally be above 8 in doing it. But it can be tolerated on a case by case basis.
Not necessarily KPV.
KPV is actually very well tolerated in kids too, and they make a great integrative peptides makes a great spray that you can use for kiddos. I like sprays in kids because they almost have more of like a homeopathic energetic effect to where it's
Mhm.
not as profound as a medicine, and kids respond so well to energetic medicine in that way. And when I say energetic medicine, when you think about homeopathics, right? We're isolating a piece of that medication or a piece of that cure. We're suspending it in alcohol, right? But it's about 100th of the potency as, let's say, an essential oil would be. So it's just kind of giving your body that nudge of being like, hey, shoo, here's this little nudge for that. Here's this little impetus, right? And so I love that with kids. In that vein, though, if you're a really, really, really sensitive person, I kind of will follow the same theory with that with people.
Got it. Got
Yeah.
it. Got it. So I think that's really cool that we're talking about peptides because it is something that we talk a lot about in the Source Lab community. I'm very open to it. It sounds like you figured out ways to incorporate them. You tell me, and then we can move on, but I just have one question out of this. The way I think about KPV in a very simplistic way, I know there's a lot going on here versus something like thymosin alpha. To me, KPV seems to tackle more this sort of innate immune piece in terms of that inflammatory aspect. It sort of quells that down. And I think of thymosin alpha maybe operating a little bit more on the other side of the immune system. So if you have a lot of antibody or T cell deficiencies, or and you're trying to clear infections or things like that, to me, it makes sense to exploit something like thymosin alpha. Certainly in that context, I'm sure there's other contexts, maybe even across the board for CIRS patients, this is just like a good thing to at least give it a try. But I don't know if you agree, if you think that more or less aligns with the function of these peptides.
I do, yeah. I mean, I think for me, the way I more visualize it is KPV is a bit more working on the motherboard, right? Like the hypothalamus. It's really getting
Uh-huh.
higher up in that mechanism, whereas thymosin alpha is lower down, right?
So
So it's
the thymus gland, or
exactly,
right.
they're like the foot soldiers, right? And
Yeah,
then KPV is like the sergeant or whoever is in the military that's sort
yeah.
of planning and plotting, right? And then other people are going out and doing the work. But I will say, KPV can stimulate a lot of serotonin production in the microbiome. So it can be very uplifting for people in terms of almost like an antidepressant
Yeah.
slash mast cell stabilizer because of that serotonergic effect of it.
I certainly, even with the oral version, when I started introducing it, I started the first things that I started noticing, histamine started going down. It
Yep.
was one of the big add-ons, and then there was definitely something in the mood that aspect that was stabilizing. So I
Mm.
can't imagine even like an injection how much more efficient. And you mentioning the work on the hypothalamus or the HP axis makes me wonder to what extent KPV could potentially help, like indirectly allow those regions to start producing things like MSH again. If there's some kind of I'm saying indirect just to be a little bit conservative about the mechanisms of action, but I'm wondering to what extent. And I think I've seen a couple of people where they do blood work and they're on KPV and the MSH levels circulating in the blood correlate with there's some kind of elevation, and I'm not entirely sure what the mechanisms are there. As far as I know, I don't know. So I don't know if it directly stimulates the MSH. I haven't come across that literature, but if it's helping quell down any inflammatory activity in those brain regions, certainly something like MSH can come back online. Or
Yeah,
it's,
yeah.
yeah,
I'm hopeful for it. I run a lot of labs on people and I haven't seen I've seen minor increases in it, but I think if you're still in exposure doing it or you're still dealing with a lot of infection using
yeah,
it, then there's not going to be as much of an influence. It'd be
yeah,
interesting to see a population, that's sort of done with the shoemaker protocol and then just doing more optimization if it would have more of a profound effect on their
yeah,
MSH. But so much of the time, I call them lifeboat strategies, right? People are using peptides while they're still going through the journey of SIRS and the Shoemaker protocol to
yeah.
where it's helping them symptomatically tremendously, but not necessarily changing the lab marker.
Yeah. The other thing I'll say about KPV and MS related to MSH is, and there's actually an interesting study that we recently discussed in the practitioner membership for CIRS Lab, looking at traumatic brain injury and what is how is MSH correlated in the aftermath of a traumatic brain injury. And what that paper showed was that depending on the severity of the TBI, the concussion or the injury, you'll see this trade-off where MSH levels get depleted in the blood, but they go really high in the cerebral spinal fluid. It's almost like MSH is rushing into the crime scene to try to quell down or manage the situation. And it's correlated with elevation of TNF alpha, which is a pro-inflammatory cytokine or
Right.
cytokine. And so there's all these interesting applications potentially, including like maybe a concussion type of situation. I had a head injury. I know you know this, not too long ago, and I started going really high on KPV right away just to try to do anything I can on my area or my end.
Absolutely. Yeah, that makes a lot of sense. I mean, alpha MSH, to me, it's one of the most regulating hormones in our body. Like there's so many effects and roles that it plays, which is, why SIRS is so far reaching in all these different systems. So it makes sense to me that it would be rushing to the scene of the crime. I think it really has so many mechanisms in the body.
Yeah. So that's great information. Maybe we can you start talking about labs. So one question I had for you was if you can tell us a little bit of what you usually run for a SIRS patient in terms of lab work, and that can include anything from sort of general lab work for SIRS or anything outside of that. And certainly we want to then jump into the gut, and how you go about exploiting that piece.
Yeah, I'm like, grab your pen and paper, everyone. It's gonna be a long list that I say right now. So, I always tell people that although I'm a SIRS practitioner, I'm not SIRS happy, right? First and foremost, I'm a diagnostician. So we always have to rule out other symptoms and different diagnoses. So I do labs outside of SIRS through Vibrant. And you could do them through any company. Vibrant just tends to have the best cash prices, but these are going to be things like an omega-3 index, a full thyroid panel, full hormone panel, lots of different micronutrients. So I run a lot. I do ADEK, B1, B6, B9, B12, zinc, copper, CoQ10. What am I missing? We do full iron series. So, TIBC, iron studies, ferritin. Some other ones that are interesting, like I run creatine kinase on people.
Hmm.
Um, Creatine kinase is a really interesting one in terms of muscle breakdown in the body. We do have three different types of muscle, right? We've got skeletal, we've got things affecting the brain, things affecting the heart. So it tells me in terms of like a breakdown situation and more of an inflammatory situation. We've got CRP, we've got ESR. What else am I missing on that? I'm sure I'm missing a few, but a really profound workup just on other systems in the body. Then from a SIRS practitioner perspective, that's going to be a bit more of the classic Shoemaker labs. I will say I don't do the C34 and C4A, like I don't do any of those testing because I don't run them through National Jewish. But I'm definitely doing a Western blot line panel. I'm doing a von Willebrand's profile also for blood clotting disorders. So those are a bit outside of the Shoemaker ones. But then Shoemaker ones, MMP9, TGF beta 1, VEGF. I do throw leptin in there as well. That's not always required. I do total histamines. I do tryptase because in the SIRS world, there's obviously a huge confounding variable of do we have MCAS? And frankly, I think that there's what I call energetic MCAS, and then I think that there's actual diagnostic MCAS, which is high elevations in tryptase, total IgG or total IgE, histamine. But doesn't mean that you can't have these MCAS histamine symptoms and not be positive for those things. The other
Right.
thing I like to put on people's radar too is if you've been on an antihistamine your entire life, like that's going to block a lot of those metrics when you're getting your blood drawn. So I'm always telling people to get off of your antihistamines for at least a week before you're doing this blood work so that we've got a true read. And then if we're dealing more with like an energetic MCAS, it has a bit different treatment profile for me, but what am I missing here? Marcon's nasal swabs we do. I don't do the neuroquant brain MRI until later in treatment because it's just part of being a psychologist's daughter, I think. It's, and excuse my French, it's a mind fuck seeing that your brain is completely deteriorating and you've just figured out what SIRS is, and now you have to wrap your mind around moving out of your house, or otherwise you're going to have Alzheimer's in a year. So I don't cross that bridge until we're a bit recovered and stable. Frankly, we can't treat you with a lot of things for that brain injury until later on in the Shoemaker protocol anyway. So I save that for later for people. So that's going to be most of the blood work that we're working up on people. Then in terms of the microbiome, every single patient in my practice is getting molecular stool testing, which is stool testing that's dealing with DNA technology. So that's 16S, or that's also going to be Shotgun. The two companies for that are Ombre or Nirvana Biome. I
Mm-hmm.
don't do culturing a ton with people unless I feel like an ulcerative colitis situation is indicated or there's blood in the stool, something like that. Occasionally I will do like a separate parasitology, or if I think something else is going on with infection, I'll do that way. And then I do SIBO testing all the time, all the
Mm.
time, because it shows up so atypically with so many different reasons. And frankly, I'm going to treat someone completely different if they have SIBO versus if they don't. So Food Marble breath testing is my absolute favorite lab work company and device because you get your own SIBO testing device that you can use forever for free.
Mm.
I'll even do it with people and families, and you can test your whole family for the price of one device. So it's amazing to have. Um, I do intestinal permeability testing with some people. That's going to be through, oh my gosh, Genova does that, but you can get it
Oh,
off.
Genova. Okay.
Yeah, but
Okay.
you can order it off Rupa. It's very affordable. It's $130. It is a urine test, so it's formerly known as the lactulose mannitol test. But I believe they promote it on there as the intestinal permeability test. So
What's the
um
name of the urine test again? Lacto.
lactulose, and then like 2 points,
Oh,
like
lactulose. Yep.
lactulose mannitol test, because those are the two sugars you're going to be ingesting. And then whatever you pee out indicates whether or not you're permeable or not, because there's a certain percentage that you should be passing or not passing. So it's been the gold
I'm
standard in gastroenterology since the 80s for intestinal permeability.
I'm seeing a couple companies. There's one that's called True Health Labs, and then DHA Laboratory. Is there a specific company for that test that you?
Genova, yeah,
Oh, the
Genova's.
Genova. This is the Genova one. Okay. Okay.
Yep. Mhm.
See, I'm just putting it in the chat for the members. I have it here. So I think it's just the intestinal permeability test. Is that what it's called?
Yep, they label it that way. And then, if you were talking to like a GI doctor or something, they would laugh at you if you said intestinal permeability test because it's kind of the trendy, cool kid in town way of saying it.
Yeah.
But the true scientific way is lactulose mannitol test.
Got it. Got it. These are all great. I haven't done any of these tests myself. I am planning on doing the Ombre test at some point.
Yeah.
I think I might find some important information there for me. And it sounds like you're very picky about SIBO testing, right? So there are these standard tests that are available, and then you have this option that you just laid out. Is there a specific reason for that?
There is, yeah. I mean, SIBO testing notoriously has been difficult because there can be a lot of false positives, false negatives, but there are three substrates that you test when you test for SIBO: lactulose, glucose, and fructose, because those bacteria that are overgrown in the small intestine can respond to different substrates. So if you just do glucose, which if you go into your primary care doctor, they're just going to do glucose with you, 30% chance they're going to detect SIBO on you. It's not a bad test, it's just an incomplete test, right?
Yeah.
If you add in fructose to that, 94% chance you're going to detect SIBO, which is super cool because you don't need prescriptions to get either of those. Lactulose, 100% of the time is going to detect SIBO if you have it. I'm sorry, all three of those, fructose, glucose with lactose, will
Yeah.
detect all of that.
Yeah.
But lactulose in America, for whatever reason, is prescriptive. So oftentimes it's difficult to get that. Like I don't have a license to prescribe, so I can't get that for my patients. So, but fructose and glucose, 94% of the time is going to get it.
Got it. Got it. Um, so speaking of the sort of this gut assessment, when in the relative to the shoemaker protocol, the shoemaker steps, do you typically do this? Do you do this from the get-go? When do you start intervening in the gut? When do you think it's like an appropriate time to do this? Does it matter in the shoemaker protocol where you're looking at when you decide to really try to fix the gut?
I think it does, and I think that there's some nuance to it. I always think that more data is better from the get-go because there are certain things that would make me treat or hold off on the shoemaker protocol until certain things are wrapped up. So for instance, SIBO really is the big one, and SIBO, methane and SIBO primarily is the one that's going to cause constipation. But you could just say even like IBS-C, right? So if constipation is going on and we're not having daily bowel movements, and then I put you on a binding medication, there's no way you're improving with that happening, right?
Yeah.
A lot of people don't realize that that binding medication, the cool thing about it is it's not getting absorbed into the bloodstream. That's why the medication is so benign. But it's binding up to that bile, it's sucking in all of that toxicity. And now you've got between 4 and 6 hours to poop that out, or it's going to be re-released into your microbiome. And if it is re-released into your microbiome, you're going to be in a world of hurt, right? So a lot of these people that feel terrible on cholestyramine are those types of people that have slow transit time and aren't getting that out of their system. So one thing I will say in terms of testing, and anyone can do this for free, right? Figuring out what your bowel transit time will always determine for me if I'm doing shoemaker protocol with you. So
Mm,
what is transit time? Transit time is how quickly does the food from your mouth exit your body, right? After you've eaten it. So the
yeah.
easiest way of doing this is eating a half a cup of corn. You can also do it with beets. You can also do it with sesame seeds. And you're looking for the first sign of that in your stool. And that starts your transit time. So let's say you see it, 6 hours after you eat corn, you see it in your stool. Then you're also going to look for when was the last time that I saw that corn. And that's also going to indicate the slowness or the speediness of your intestines. So ideal is 6 to 8 hours. The longest I had for a patient was 3 weeks until we saw that corn come out of her
So
stool.
were there any bowel movements in that
There
period?
were bowel movements, and that's what's confusing is people will be like, well, I poop every day. And I'm like, that doesn't mean that that transit time is efficient, because transit time is a sign of how well does the nervous system, that myenteric nervous plexus, how well is that squeezing and getting things moving throughout your bowel. So if that's dysfunctional, right, you'll still be pooping, but you won't be getting that full expulsion. And a lot of people will say that I pooped, but it just didn't feel like a complete bowel movement to me.
Mhm.
That's another one of those signs of having a dysfunctional nervous system in the
Got
microbiome.
it. And how you go about speeding that up if you find
Yeah,
that?
that's a great question. There's a couple prebiotics that are really helpful for that. There's also a couple probiotics that are wonderful for that. I'm not a big fan of people just being on any willy-nilly probiotic forever. I use them for their mechanism of action. So there's a supplement called Fluorocist Daily Bowel Mover. I'm pretty sure it's Lactobacillus rhamnosus GG, if I remember right. I always get my Lactobacillus strains mixed up, but that one specifically works on transit time, right? And you don't need a lot. You need one in the morning, you need one at night, and it's going to start moving that. I will say, short of people that have, IBS with diarrhea, if you're dealing with constipation or incomplete bowel movements, most people can benefit from that probiotic. So it's pretty profound.
Got it.
Biogaia is another one that's helpful as a probiotic. And then lastly, in terms of fiber, partially hydrolyzed guar gum or sun fiber, which is the only prebiotic that is well tolerated in SIBO. So it's pretty safe for most people.
Got
That
it.
coffee I had this morning had a giant scoop of sun fiber in it.
I see. What if someone is on a low carb diet and you're trying to assess the gut? Is there anything that you do different in those cases? You know, some people will resort to something like that, sometimes like carnivore diets or because that's all they can manage. Do you have any way of working around that differently?
Yeah, I mean, I don't necessarily work around it differently. It just informs me on what is probably happening in that ecosystem because
Yeah.
in order to feed bacteria, we need carbohydrates, right? So, but I'll have some carnivore people that are like, I had this one carnivore guy that had been carnivore for 4 years, but every night he drank this drink that had a ton of inulin in it, which inulin is a prebiotic fiber from onions and garlic. And his microbiome actually looked pretty wonderful just from doing that. So again, it informs me of what I'm probably going to see in a stool test. And then based off what I'm seeing in your stool test, I can tell you what you need to eat more of, right? To feed those bacteria. So I'm
Right.
not a big fan of one diet is good, bad, best, whatever. I need to see your microbiome and then we can talk about that.
Yeah, maybe we should talk about that. And I'm interested in hearing a little bit about how you treat SIBO or Candida overgrowth or maybe even actinobacteria if you see it, because it's something that we talk a lot about in the membership as well. But
Yeah.
yeah.
Yeah, I mean, so SIBO and SIFO they're pretty complicated, right? In terms of like how one goes about treating them. I would say simplistically, we need some sort of antimicrobial in the mix, right? Allicin, which is the active component of garlic, is pretty common as a mainstay in that. Then you have different things like oregano and thyme and pomegranate husk, that are pretty heavy lifters as well. So depending on if you are SIBO dominant or SIFO dominant, which can be confusing because they cross feed each other, right? So I do a lot of silly metaphors because I'm totally a kid at heart, but they're like best friends on the playground, right? So it's very common if you have one, you're going to have the other. But what the nuance is which one's the dominant one? Like, what's the bully on the playground? And if you can figure out that, then that's the bulk of your protocol. And then I might weave in, like we talked about Horopedo, I might throw in an antifungal, a botanical antifungal to assist in that. Um,
Hmm.
but I play a lot with that with people because if I put them on an antimicrobial protocol, and they're like, yeah, I feel better, but like, I don't know, I'm still super bloated by the end of the day. Right around 4 to 5 weeks, I'm going to be shifting that, right? And I'm going to be then targeting more of like a CIFO approach rather than a SIBO approach. Um, so there's a bit of dancing with that in terms of how we treat that. But the other aspect of it outside of antimicrobials is really seeing what does our beneficial bacteria look like? What do our butyrate levels look like? Because butyrate is the primary fertilizer for the microbiome. So I can't restructure your microbiome if you don't have butyrate, right? I can kill off these guys, but if your body or if your biome remains to be alkaline, they're going to come
Hmm.
right back, right? So we have to reacidify the body. And, this is a big concept with actinobacteria too, because actinos thrive in an alkaline environment.
Yep.
everything that we do in our culture alkalizes the body. And I know that sounds really trendy because, alkaline water has been a thing. We want alkaline blood, we want an acidic microbiome, right? So to get an acidic microbiome, you need butyrate. Butyric acid is what acidifies you. So, everyone thought you could do it through butter. You can't do it through butter. You need to do it through resistant starch, prebiotics. So this is where the carnivore peeps get into trouble with this. But that re-acidifying people, when people don't have a lot of money and they come to me, all I do is push butyrate production for them.
Do
I'm
you start early on if you're doing
early
streaming?
on, early
Okay.
on. If their butyrate production is less than 20%, they're on butyrate with me, like a very high dose of exogenous butyrate, right? So putting it in your mouth.
Yeah.
If you're above 30%, then you're eating green bananas every day, right? And you're eating cooked and cooled rice every day. And I'm going to try to push some legumes with you as well. So it kind of depends on a case by case basis, but the butyrate alone is probably the most profound thing you can do for your biome. And then obviously these other strategies can provide some more specificity in getting the bad guys out.
Got it. Got it. Are there any antimicrobial supplements or herbs that you do not necessarily recommend or you want to be cautious around using them?
I'm so glad you asked that. That makes me so happy. Yes, totally. So just in like herbology, right? Essential oil versions of things are the most potent. And we can all relate to that. If you were to pour oregano oil on your hand, like you'd be in a world of hurt, right? So when you're taking a capsule filled with oregano essential oil and then that's opening up in your stomach or small intestine, there will be damage to that epithelial layer. So I'm not a huge fan of essential oil versions of things. I really love using tinctures, right, to get the job done. Garlic also is well tolerated in terms of like a potent, more fiery antimicrobial. But berberine, I have a whole slide in my CIRS PowerPoint that says berberine beware, right? Berberine is very potent. It's a very, very potent antimicrobial. It's just as potent as using an antibiotic. But people are, it's sort of the functional medicine golden child right now for blood sugar regulation. And not that it doesn't do that, it does help with blood sugar for sure, but at the cost of your microbiome. So two things happen when you take berberine. One of them is you will spike E. coli upwards of 400% of what it should be. So you're basically causing a massive E. coli infection in your body. And then it's
Hmm.
also destroying diversity and beneficial bacteria. So, I mean, I've had people that have been on berberine for years that come to me and there's just straight up certain strains that don't exist anymore, right? They've completely killed them off. So I think it's super negligent to use berberine in practice, actually. Yeah, I
Yeah,
rarely use it, and if I do, it's for like a week.
got it. Well, I'm one of those patients and I'm taking note of this. And I know you talked about it before. It's a interesting situation, but I think I'm hoping I can minimize the product that I'm using that has berberine in it. And I think I'm getting there. But I think that's a very important thing. Also, I know from the off the top of my head from some of the literature that I read that berberine could potentially alter um, mitochondrial activity specifically as it relates to the closure of the VDAC, these channels. It can have alterations there that may not actually be desired for CIRS patients. So there's also activity at that level in terms of closing these channels, right? That I know Dr. Shoemaker talks a lot about in the context of antifungals, like prescribed antifungals that can sort of change the function of mitochondria or just cellular functioning and in terms of energy output. And yeah, so there's definitely nuance to this that I think it's hard for us patients to wrap our heads around it sometimes because we're just thinking about surviving
Oh,
and
we're just so desperate, you'll do anything to feel better. So, but again, like I tell people a lot, when you're called to be a doctor, first and foremost, you're called to be a teacher, right? Which means you need to be far more informed than your patients, right? But then secondly, you're called to be a Sherpa, right? You're called to lead people up Everest, but you've climbed it before. And it doesn't mean that they don't have to climb Everest, they do, but there needs to be this education component of it. So we're not, falling through the crevices, falling 500 feet. So just because something's natural and something's botanical doesn't mean that it's safe, And so, and I don't blame a lot of practitioners for not knowing that. This is something that's often not taught a lot.
Yeah.
But it needs the news needs to be spread, right? Of
Yeah.
that certain things can be really dangerous for people.
Yeah. 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 I agree. So maybe we'll have about 8 more minutes to kind of talk and then we'll open for Q&A. And I guess one question I had off the top of my head was, do you see a correlation with treatment of, let's say, Marcons and the gut getting better? Is that something that you've seen in your practice? We talk a lot about how clear Marcons can help restoration of MSH, and in theory, MSH should be one of these things that can contribute to promote a more healthy or functional mucosal lining.
Yeah, yeah, absolutely. Yes, and also it's just so frustrating because some of these infections are so tricky in the sinuses. But yeah, I mean, if we just think about it mechanistically, when you sniff and you swallow, that's going into your microbiome. Now, the cool thing about that is if your stomach is acidic enough, you're going to usually kill off whatever you're swallowing from your sinuses. But again, this comes back to that prioritizing acidity in the microbiome. If you've got a Marcon's infection that you can't clear, you can't treat yet because you're still in exposure, then you bet your ass we're going to get that microbiome as acidic as possible because that's going to be one of the biggest frontline protectors of that. But no, I absolutely think that that infection is going to contribute to the microbiome and having
Yeah,
dysfunction. Um,
yeah,
it's just a slow drip of microbes that aren't beneficial, right?
yeah. Is there does this concept of acidification apply to, let's say, the mucosal linings in the sinuses as well, or is it just in the, stomach and then anything below that?
No, yeah. So there's many microbiomes in the body, right? With all varying degrees of pH. Actually, the most acidic microbiome is for a woman in the vagina, right? Actually, in terms of like the bacterial species, it should be 80% Lactobacillus acidophilus, which is like insane to have that dominance of that. This is why for a long time people have been doing boric acid suppositories into their vagina to keep intense acidity in there, right? So vagina is most acidic, biome comes next, and then as we keep traveling up, it gets a little bit less acidic, but still across the board acidic, right? So the sinuses for sure are acidic as well, just not as intense as lower down and then midway. I've never experimented with reacidifying the sinuses because I wouldn't consider myself an expert in that. It would be really interesting to find someone who is, but I would say that the same concepts apply in that maybe like a probiotic nasal rinse could be beneficial from that, right? Obviously, some antimicrobials can help with that. I know that the spray that you were messing with, Christian, is really helpful. The propolis one, I could totally see that being really acidifying. So that's what I mean is it's like I think that the microbiome signals to the rest of the biomes of how they need to be. So I'm a big fan of establishing that first in the microbiome. I see that all the time in the vagina. If I can get your microbiome to be acidic, then your vagina follows suit. So I do think that these other things kind of follow suit, but to have some of these lifeboat strategies that are pretty benign in the meantime, right, to keep that acidity going, I think would be very useful for sure.
Yeah, yeah. You mentioned Lactobacillus acidophilus. Do you use that as a probiotic in
You
that
know,
attempt? Yeah.
I don't very often. I use some other lactobacillus strains more commonly. I do use it in the vagina for sure. There's a great probiotic called Femdophilus that if you're struggling with chronic yeast infections, you can do a suppository of that. But actually, there's a prebiotic called lactulose, that is super acidic. The problem is it's it's a prescriptive medication, but I've had women soak like a tampon in that and put that in their vagina, and that will reacidify really dramatically.
Okay, yeah, I was trying to look for the product, but if it's prescribed, then no, I
Yeah,
guess
lactulose is a prescription. You can get it pretty commonly because it's used as a laxative. So especially if you struggle with constipation, you could probably pretty easily go to your primary and say like, "Hey, I'm really struggling with this. Can I try this?" It's also like $8 for like a 2-month prescription. So,
yeah,
because it's sugar syrup, basically. It's like
yeah, yeah.
lactose sugar syrup.
And which of the tests are you using to determine if there's a lot of alkalinity in the mucosal linings in the gut and elsewhere?
That's a great question. So if you do culturing, there's always like there'll be a pH section where it tells you what your pH is. So pH is always paradoxical, right? So alkaline is high and then acidic is low. So you can find it that way. You can also do it yourself. I mean, it's a little bit gross in terms of how you can do it, but basically you'd take a bit of your poop and you mix it with some water and you get a pH strip and dip it into it to see where you're at. So I've had patients do that if we're not going to do culturing. But you could use those pH strips as well to lick or to wipe your vagina with, and then you could see your pH that way. So that's how we're testing those different biomes.
I see. So it's not something you would get like in the Umbra testing or something like that.
So Ombre is not gonna, molecular testing is not gonna have those like functional type markers.
Got it.
But it's not hard to do. And I'm sure you could do like even like a quick YouTube, like how do you test the pH of your stool? And have a guided video of how to do it.
Yeah, 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 yeah. No, that makes sense. Do you do any biofilm treatment, or do you think it's a good way to go about for certain people?
Yeah, I mean, biofilms are everywhere. We all have biofilms, good ones and bad ones, right? So, but there are certain species that come along with strong biofilms. So, strep is one of them for sure. Whether it's strep A, strep B, strep O, they all kind of have different components to it. But then any sort of fungal overgrowth, like a true candida infection, is going to have some pretty dramatic biofilm. So if that happens, then I'm going to be using some sort of biofilm disruptor for that. But I'm cautious because I don't want to destroy the healthy biofilms, right? So it's really only in severe strep cases and severe candida cases that I'm going to be doing that. But prepare your heart for die-off because breaking apart biofilms, those little guys hold on to a lot of other bullshit in them. So you do want to be on some sort of binder when you're doing that. For intestinal infections, and so this is not for mold specifically, because obviously we know this is controversial, but for intestinal infections, bentonite clay is the best binder for LPS specifically when that's getting, removed or expelled from those biofilms. So big fan of
Yeah.
that. Mhm.
Okay, so in terms of binding, I actually I've been using a lot, not a lot, with intermittently GI detox, which is what I think has bentonite clay. And I don't know if you're a fan of binding binder products that have multiple binders in them like that, or if it's okay
I'm
or
not,
not.
I don't think that they're problematic. I just don't think that they work as well, right? So
Mhm.
with so many things, dosage really matters. So probiotics, if you're not getting 10 to the 6, right? You see those exponents when you're looking at them. If you're not getting that level of quantity in the probiotic, it's not going to have a therapeutic effect on you. So that's just a bit of a side note. But same thing with binders. They're a bit competitive with each other. So they're going to neutralize the effects of their neighbors if you're taking them all together. So I'm not a big fan of doing combo binders.
Got it. Got it.
If you do
Going back,
multiple binders, then I would just do them separately. Like I would do bentonite clay in the morning and then I would do charcoal in the evening, kind of a thing, right?
I see. I see. Going back to maybe this might be my last question and we can do the Q&A, but going back to Oropito, so just to be clear, are you using that as a broad spectrum antimicrobial or are you using it for very specific things that you see in these stool tests?
Torpedo is specific to fungal overgrowth for
Fungal.
sure. Yeah, so it's quite specific and it's also quite preserving of beneficial bacteria. That's why it's probably one of my favorite antimicrobials. Black cumin seed is also one of my favorite antimicrobials, but black cumin seed is going to be more broad spectrum. So if someone's struggling with viruses, bacteria, parasites, like that guy kind of covers all of them. Horopedo is specific to fungal overgrowth. So if you're
Yeah.
struggling with candida, if you have high levels of prevotella in the microbiome, high levels of actinose in the microbiome, Horopedo is my absolute go-to for that.
So actinos is in that category. It's interesting because, actinobacteria it looks, or certain species look like fungal, like a fungi, right? But they're classified as bacteria. And I always wondered, many times it looks like we may have something fungal, maybe we do, but then in my personal experience, at least for me, it seemed like under all of that, or a lot of it, was actinos, and it's not easy to tease them apart, but it's cool to see that there's an herb that can potentially tackle both sides.
Yeah, gosh, it makes me want to have a degree in microbiology, to like really get the nitty-gritty of it. Cause I agree, like it has fungal behaviors, right? And again, it sort of plays with fungus a lot. So there's all these cross-feeding relationships in the microbiome. So this gets into kind of like a nerdy tangent, but when you're looking at a microbiome and you see high levels of Bacteroides in the gut, which can be gram negative and it can be infectious at too high of a level. But if you have that, it's actually protective of Prevotella. So you're only going to be dominant in one or the other. And then once you determine that dominance, let's say you're high in Prevotella, but low in Bacteroides, Prevotella feeds fungus always. They're always together. So this is what I mean in terms of like nuance of seeing what to treat and what to use. If you're low in Bacteroides, I'm not going the black cumin seed route. I'm looking at your Prevotella and then going the Horopedo route, right? So this
Got
is
it.
we choose those antimicrobials based off of cross-feeding relationships, dominance in the microbiome, which beneficial ones you have, which ones you don't. So there's some nuance to that for sure.
Got it. Got it. That's really, really helpful. And for everybody else who's listening, I'm actually experimenting with the oropito or oropito. I don't know. My Spanish
Yeah,
is,
you definitely you pronounce the H for sure. It sounds far more beautiful pronouncing it the way that you are. Horopedo, in my American accent.
yeah, yeah,
But yeah, it's actually a part of the oregano family, but it's not as potent as it. So it's just lovely. It's a lovely herb from that sense.
yeah. So I'll be certainly talking more about my experience with the membership in that regard. So I appreciate it that you brought this back because I had tried this maybe like 3 years ago. I don't know if I was ready for it, but I feel like I can tolerate it now.
Yeah.
And
The,
yeah, so I
the,
think
the
that,
die off from it can be pretty intense. So I always tell people start at night because hopefully you sleep through it, right?
yeah,
But it can be kind of it can just cause a lot of tummy aches. It really does. So that's the best way of describing it. It's just like a tummy ache about an hour after you take it.
yeah,
And that usually lasts about a week or 2 weeks and then it goes away, right?
yeah, yeah. Great. All right. So maybe we should jump into the chat. There's a lot of questions, and I think these are interesting questions. So I'll just read them out loud and then we'll see. So for the first question, it would be great for you to go over the timing of treating SIBO and SIRS and if SIBO can be during exposure to actinos and or endotoxins and marcons. And does she recommend the rifamycin or alicin protocol or just
Allison.
those? Yeah,
Allison, yep. So many great questions there. So it's a tricky answer for can you treat SIBO while you're in exposure, right? I think that you can, but I think that you need to have the expectation that it's not going to go away, right? So a lot of people though are in such a world of suffering with their SIBO that I think it's worth it, right? But this is where we get into, but how are you treating your SIBO? Because if you're on a grip of berberine and a ton of rifaximin, then I'm not treating your SIBO. Those are my options. But the way that I'm doing it with prebiotics and gentle antimicrobials like that. I feel very confident of doing that safely for a very long time. But when you are in exposure, this is what's so interesting about having the food marble. Breathing in mold, breathing in mycotoxins alkalizes the microbiome, and you'll see a massive spike in methane when you're in exposure. So
Mhm.
I'll do that like because I've struggled with all different kinds of SIBO, but if I walk into a moldy building or something, I'll have my little device and I'll breathe into it and my methane will be off the charts, right? So this is what I mean in terms of like the cross-feeding relationship is like methane spikes and then it brings along all of its other friends, that's SIBO friends. But I do think that you can still treat it. Now, I usually give my patients the option because again, if money is tight and you don't want to be spending thousands of dollars every month on different supplements, then I don't think there's anything wrong with not treating it until you get out of exposure. But I
Yeah.
think that your symptoms will be more profound if you don't deal with it. Now, if you have constipation, severe chronic constipation, I do not start the shoemaker protocol with you until you're pooping daily. Like I will not do it with people. So if that requires me to be doing a SIBO protocol in preparation and you're still in exposure, I'm absolutely doing that because pooping, nothing is more profound for your body other than I'd say good oxygen than pooping every day. Right. So I'm trying to think. Oh, then you asked about rifaximin or allicin. So I'm not a big fan of rifaximin. When you look at efficacy rates, it is efficacious. Like it does clear SIBO. I think it's 92% of the time, but the reoccurrence rate is 80% of the time. So those aren't great odds, right? It does get rid of it, but it comes back 80% of the time. Botanical medicine doesn't have those same metrics. Botanical medicine also clears it 92% of the time. However, it takes way longer, but it doesn't come back, right? I mean, it does, but I think it's 20% reoccurrence rate versus the 80%. So I like those odds way better. And then also, anytime I'm looking at a medication, I'm asking myself, does it giveth and does it taketh?
Mhm.
If it taketh a lot, then I'm not going to be as big of a fan of it. So berberrium's in that category for sure, but rifaximin as well, or any triple antibiotic therapy that you might be on for SIBO, because you're going to decimate all that beneficial bacteria. And this is why it comes back 80% of the time, because you're not acidic anymore and you've wiped out all of your good bacteria. Now, of course, there's nuance in that. If someone is really, really extreme and they don't have the patience to wait 6 to 8 months for the botanicals to really do their thing, then every once in a while that's happened. But I don't see great success with rifaximin.
Got it. Got it. And would you put Atrantil in that category as well?
Atrantil's okay. Atrantil is a nice sort of kind of put it in more of like an anti-inflammatory category. I think other things are more heavy hitting than Atrantil, so it wouldn't be my go-to. But if someone's on it, I'm not like, oh, it's gonna cause you problems. I just don't think it's heavy hitting enough.
Got it. Got it. Next question. Have you ever used the peptide LL37 for actinos or other infections like Lyme or other co-infections, Candida, or any kind of colonization?
I have used LL37 personally and with a couple of patients. I do not use it until their microbiome is very optimal and until they are quite stable as a patient because it can go either way. It can be pro-inflammatory or it can be anti-inflammatory, and it will be pro-inflammatory if your cytokines, the MMP9 and TGF-beta1, are not resolved yet. So I don't mess around with L37 until those later phases, which is why I haven't used it a lot because, it takes so long for so many patients to get to that point. I've personally used it, and it was pretty intense. I mean, I'm used to a good amount of die off, and it was like a 7 out of 10 of suffering, right? Which is pretty
Yeah.
high for me. So,
Yeah.
and do I feel like it moved the needle more than anything else? No, I don't. So it wouldn't be my favorite, honestly.
I tried BPC 157 and I had I don't know if I should say similar experience, but I did have like a histamine flare up. It was like something was being triggered and I stopped it. And I stuck with KPV and that, to do something that has overlap in terms of the gut and that kind of stuff.
Yeah, a lot of people, this was from my training with Tees, but when people have problems with histamine or allergies or food sensitivities, you're having a reaction to protein in your body.
Hmm.
Your body is tagging specific proteins, right? So when you're taking peptides, peptides are specific proteins.
Hmm.
So a lot of times when you have that hypervigilance already, and now you're adding a pretty high dose of specific proteins, it's very possible that your body is going to tag that in the same way that they're tagging kale, which doesn't make sense that they are tagging kale, but that's the mechanism of autoimmunity is hyper tagging those proteins. So this is where I don't love peptides for that population.
Got it. Now that you said KO, I want to ask this on my end really quickly because I know a lot of people will be interested in this. Oxalates. I know you've talked about it. So people are really concerned about oxalates. Is there a mechanism of action here that we're not taking into account in terms of tolerating them?
Totally, totally. I feel like I've been asked this question like 5 times this week. It's so funny. So there is a bacteria in your biome called Oxalobacter formigens. It is the bacteria that is responsible for digesting oxalates in your body. Many of us, if you don't eat oxalates commonly, you'll lose that bacteria. And when you lose that bacteria, you don't have the capability of digesting oxalates. So people that have a high oxalate sensitivity, ironically, is from a lack of that bacteria. Now, when I do stool testing on people, I can see that level. And if you're hanging on and there's a little bit of that, I want you to eat oxalates so that you can slowly bring that bacteria back and then tolerate those foods more. So the reactions are valid. The reactions absolutely happen. But the cure to me is not to avoid them, because if you avoid them, you'll kill off that bacteria and never be able to tolerate them. So, yeah, that's my take on
Okay.
oxalates.
Thanks for sharing that. So next question. My kid had to stop treatment because of lots of stomach pain and uh are get we're getting gut testing done before restarting. I think it's they means the doctors. The doctor suggested a GI map. Would you recommend that test?
Nope, not a fan of GI map at all. I'm not a fan of any culturing technique, so I don't just like have it out for GI map. I mean, I don't like vibrant gut zoomer. I don't like de novo. I don't like any of these culturing techniques because, and Christian and I talked about this at length. You lose so many of those species in transit because the sample is heat sensitive. So if your child is struggling with blood in the stool, or they're struggling with what someone might think would be ulcerative colitis, then a culturing stool test would be great, but only to look at, is there blood in their stool? Is there fat in their stool? What are their inflammatory markers? In terms of actually looking at what bacteria make up their microbiome, you need a molecular test. So a test based in DNA, which is either going to be in America, Ombre, or Nirvana Biome, right? So if money is a non-issue, do the GI map and do Nirvana Biome, and that will give you the full perspective of what's going on with her. But if she's or him, I don't know if it's a boy or girl, but if there's a lot of stomach pain going on, stomach pain and dread. So the symptom, like the actual psychological symptom of dread, deep fear with stomach pain is almost always fungal infection or H. pylori in the stomach. So then you need to do things to diagnose that, which the H. pylori test is a breath test that you'd be doing for that. And then eventually it would be an endoscopy if that's indicated. But all of those other things that I said would give you enough information to diagnose that in your child.
Yeah. Okay. Um, oh, what was the second? So you mentioned two probiotics. There was Fluorocyst and there was another one, and I think we all missed the name of the second one.
BioGaia. Bio.
BioGaia. Let's see
Yeah,
if I
you're
can.
right. It's on
Gaia.
Amazon. It's lovely. BioGaia. And it's a chewable. They make it in drops for babies, they make it in chewables, they make it in capsules. It's a wonderful, wonderful probiotic. I literally any GI condition it will benefit. So I'm a big, big fan of BioGaia. Also very acidifying for the microbiome.
Got it. I'm intrigued by this. Are you okay with like yogurt or fermented foods for a source of probiotics, assuming you can tolerate them?
It depends. Oh, there's a lot of depends ones for that. So if you can tolerate the food, that's one. Do you have histamine overproduction? If you do, I would not be eating those foods. Do you have SIBO that's lactulose sensitive? Then dairy is going to throw you for a loop on that. So I do love those foods for getting probiotics from them after your gut has healed. They're not
Afterwards.
great healers to begin with. They're great healers at the end, or I should say they're great restorers once you've gotten microbial balance in your microbiome.
Got it. Got it.
There can
Um,
there can be some yogurts that can be helpful with that, like Nancy's was like the Nancy's grass-fed yogurt has very high levels of bifidobacterium in them. So if you can tolerate dairy, that one is lovely. And actually you can crush up a BioGaia capsule, a couple of them, put it in that yogurt, leave it in your fridge, and it will expand and you'll have an even higher dose of that. But again, there's just certain people that aren't going to tolerate yogurt with their
yeah,
biomes. Yeah.
yeah, yeah. What is the time separation between sun fiber and well call, if any?
Oh gosh, that's a really good question. I mean, well call technically doesn't have as big of a window as cholestyramine in terms of like how far apart you want to take it. I would say minimum 30 minutes. And I'm just saying that because you spend good money on those supplements and you want them to have the best effect as possible with them. So I would say 30 minutes of spacing would be
Got
ideal.
it.
Yeah.
Okay. Next question. What is your philosophy around POTS and why these people with POTS need betaine? Heck.
Oh, betaine HCl. Yeah.
Yeah,
Um,
ACL. I think that's what
yeah.
this person. Yeah.
POTS is a symptom of SIRS. There are some more primary brain disorders that can cause POTS as well, but in my practice, I've never had someone with POTS that wasn't driven by SIRS. And the reason why is a hormone called ADH, which stands for antidiuretic hormone. So I
Yeah.
jokingly call it the hold on to pee hormone, right? If that drops, you're peeing really frequently, which doesn't seem like that big of a deal, but there's huge fallout from that, namely chronic dehydration, but also loss of blood volume in your body. So as that blood volume lowers, you're not getting blood to the limbs, right? So fingers, toes, penis, head, nose, blood's not getting to those places, right? And when that happens and you stand up, or even in severe POTS, you're just sitting there and you turn your head, your body says, we have no hydraulics left. We can't get blood moving quick enough to those areas. So now we're going to spike your blood pressure so that we
Hmm.
can get it to those areas. I should put down, we're going to spike your blood pressure so we can get it to those areas. And this is POTS, right? So, one of the number one treatments for POTS is salt, right? Because salt helps you retain water and increase your blood volume. But you're never going to fix the POTS until you're out of exposure. Frankly, you don't want to. It's a brilliant mechanism from your brain saying, get this bullshit out of my body and pee really, really frequently. So you don't want to over medicate at POTS until you're out of exposure, which is why in the Shoemaker protocol, you don't do desmopressin, you don't do any ADH strategies until you're out of exposure. So anyways, in terms of betaine HCl, I've never used that as a cure for that. I'm not really sure as to why one would. I mean, definitely acidifying the stomach is a good thing, but that should be my next slide after my berberine slide is betaine HCl beware, right? It's one of these things in functional medicine that has become a belief with very little evidence to it.
Yeah.
Very, very little evidence to be using betaine HCl, and you can have pretty severe consequences to it. So I hardly ever use betaine HCl in my
Yeah.
practice. You
Okay.
can
That's good
literally
to know.
cause SIBO just by taking betaine HCl.
Oh, interesting.
Mhm.
Interesting. Even though well, I mean, yeah, so I mean, right, it's a stomach acidity. It's supposed to contribute to that.
It doesn't seem logical, but what happens is when you're acidifying the stomach and or taking a product with betaine and what's it called? Ox bile, right? You are dumping bile into your body because of that, because high acidity in the stomach signals to the gallbladder to dump bile, which again might seem like a good thing, but there is a type of SIBO called hydrogen sulfide SIBO, and
Mhm.
that form of SIBO lives off of bile, right? One of the bacteria that causes that is called bilophila, which means bile lover, right? So this is totally what happened to me. I popped betaine like it was candy for probably 10 years of my life, right? And then
Yeah,
developed severe hydrogen sulfide SIBO because of it, and Barrett's esophagus because it was burning my esophagus, right? So again, major consequences to taking betaine HCl. There are way better things to do that aren't going to cause you problems.
got it. Got it. So next question, if uh, is actinobacteria a problem if leaky gut is present, even if it's commensal?
Oh, that's a good question. I don't really think about them together, right? Because you can have leaky gut from so many different mechanisms, not necessarily actino. Like it wouldn't be one of my main drivers of intestinal permeability, right? So, and if you did have high levels of actinobacteria, we can break down actinos into pathogens and anti-pathogens. So when you're looking at that breakdown, again, this is why you need molecular stool testing. Bifidobacteria is helpful and is considered an actinobacteria.
Right.
So we want high levels of bifidobacterium. But if bifidobacterium is making up a teeny tiny bit of the overall actino category, then there's definitely an issue going on, and that would want to be treated. But I don't see direct correlation with high actinos and leaky gut. I don't even see a direct correlation with SIRS and leaky gut. It doesn't mean that that doesn't happen for sure, but it's not one of these always guaranteed, like, oh, you have SIRS, you have leaky gut. Like, that's definitely not the case.
Yeah, I've seen people where they don't experience any leaky gut issues, at least on the symptom front, and they can tolerate a lot, and even their MSH is low. So there's certainly times where these things are not, it's not a one-to-one mapping. It may be a correlation at a very general level, and there might be other things happening right between that relationship that maybe we still don't fully understand.
It's a
But
contributing factor for sure,
yeah.
right? But there are other things, like if you told me type 1 diabetes, there's a 92% chance you're permeable if you have type 1 diabetes. So
Hmm.
there's far other things that if someone came into me with a diagnosis, even not just type 1 diabetes, major blood sugar dysregulation, it's pretty guaranteed you're going to have permeability. If
Yeah.
you drink frequently, guaranteed intestinal permeability. So that's what I mean is it's just a deeper workup than just
Yeah.
that.
Yeah. Okay, so the next question is, what if you have severe reactions to butyrate?
That's really interesting. I had this conversation with someone yesterday. So butyrate, if you have severe reactions to butyrate, it's almost always because you have infection, right? Because what's happening is you take that butyrate, which again, benign, right? Not causing you problems structurally, even though you feel shitty taking it. But what's happening is you're reacidifying your microbiome and you're having die off, right? Those bugs are creating mass suicide because they can't survive in an acidic environment. So you would do a lot better if you sandwiched that with some antimicrobials, and then you'd probably be able to tolerate butyrate. But you'd also just have to change your perspective of it's gonna be difficult 2 weeks, right? We're gonna be
Okay.
dealing with some die-off. Let's get some other strategies on board so I can survive this. And then once you're over that hump, it should be wonderful for you.
Yeah, yeah. Okay. Next question. How do you increase stomach acid when a patient has epigastric pain from apple cider vinegar, curcumin, or betaine, HCl, and those things?
I would say that that wouldn't be my focus. I very rarely sit here as a practitioner and say, I got to reacidify the stomach, right? The only time I'm really thinking that is if someone truly has, oh my gosh, not H. pylori. it's an autoimmune disorder where you attack the intrinsic cells in your stomach lining and then like literally can't make acid anymore. But again, fairly rare. So it's not one of the lenses I'm looking through. I'm looking at a bunch of other things to acidify lower down, not necessarily your stomach, because most people's stomach do a pretty good job of that. I mean,
Yeah,
I will say you can, if you struggle with doing apple cider vinegar, turmeric, some of these other things, there could also be some other issues in your stomach structurally, like an ulcer, like some actual structural things going on to where
yeah,
those things are irritating you. So then I would go more to like a glutamine, right? Or a DGL or a slippery elm, throat coat tea to see, ooh, do I feel way better when I take that? And if the answer is yes, you probably don't need more acid. You need to
yeah.
soothe that tissue.
Uh-huh. That makes sense. Do you have any thoughts on dysbiosis in the large intestine without the SIBO component?
Yeah, absolutely. So when we're doing stool testing, we're looking at the large intestine. Small intestine, to look at the small intestine, it's either going to be endoscopy or a breath test. So when I'm looking at the stool test, I'm looking at that composition, large intestine composition specifically. So yeah, I mean, there's a very profound pattern that you want to have in that part of the body that we would optimize through stool testing for sure.
Yeah. Okay.
Yeah, because not everyone has SIBO, right? Like I
Right.
joke because I think all the names are really cute, but it's like SIBO, SIFO, EMO, LIMO, right? So you can have methane overgrowth in the large intestine or
Yeah.
everywhere in the intestines. You can have dysbiosis just in the large intestine. And frankly, that would be favorable because it's far more easy to modulate that.
Yeah.
SIBO always makes things more complicated. So
Yeah. Okay.
yeah.
That makes sense. We're almost at the 30-minute mark. Is it okay if we take a few more minutes? There's a couple more
Yeah, yeah,
questions.
yeah, yeah,
I
please.
think people are asking really good questions here. Do you ever treat patients with gut and or bladder actino infections? And is there something that works best for that? I mean, we've kind of touched on this to some extent already, but yeah.
Yeah, definitely. Again, it's sort of with the actino family, it's definitely targeting some antifungals, but it's also just really figuring out how can we acidify you so that those guys can't survive long term. So lots of strategies with that. There is a biofilm perspective on that and destroying those biofilms. There's also a huge liver component because your liver is the waste management facility of your body. If you're not utilizing that well because of these infections, we need to support that to be able to get you to heal as well. So, biofilms, specific antimicrobials, liver support. This is where, though, if you've got major bladder biofilms, BPC 157 is incredible for bladder biofilms. Even if you
Mm,
just typed into PubMed BPC 157 peptide and bladder biofilms or chronic UTIs or what's the other one? That's the chronic bladder infections. It's escaping me, but it's amazing for that. So that would probably be part of my protocol too, is using BPC 157.
got it. Got it. Um, let's see. Mm, okay, so I don't know how to approach this, but I'll just say it out loud and see if there's a question here. I never knew this about berberine. I've had to use, oh my God, I can't read today, oregano oil and GSE for decades, and I wonder what I've done to my gut. Can you speak to this during the Q&A? I mean, you've already touched on it, I think, but I don't know if there's anything else you want to add there.
Yeah, I mean, there's just so much destruction that happens. I'm actually pulling up this slide because I think it'll be helpful for you guys. Am I able to share
Yeah, you
this?
should be able to share screen.
Okay, cool. Let's go here. Do. All right. Berberine beware, right? Okay, cool. So this is just looking at some specific research with this, right? So 12 weeks, use of 600 milligrams twice daily, which is quite common, right, for people. Like you said, you might have been on it for years. significant increases in proteobacteria. Proteobacteria are infections in the biome that are, I would deem, the most dangerous, right? So things like E. coli, Klebsiella, Salmonella is in here, C. diff is in here. So significant increases in proteobacteria after 12 weeks of doing that. And it also bloomed 9 species of Bacteroides and Fusobacterium. So Fusobacterium is the bacteria indicated in colon cancer, right? So
Yeah.
dramatic. Then we look at 16 weeks, right? Significant reduction in ecosystem gene richness. So we're losing now species after species. Think forest fire, right? We're just wiping out different things. Reduction in overall Firmicutes abundance and Roseburia. These are 2 of your main butyrate producing bacteria. And then again, significant increases in proteobacteria, but specifically Klebsiella and then things in the E. coli family are what happened. So
Yeah.
these are the specifics of it, right? If you guys wanted me to include, these are the research citations here, so I could put that, or I could send that to you, Christian, if you.
Yeah, that would be great. Thank
Yeah,
you. I appreciate it. And
yeah.
for those of you who don't know, Lacey is going to be a speaker at this year's CIRS, and she's going to be talking about this. So at some point, her presentation will become publicly available, the
Totally.
recording. And so you'll be able to revisit that stuff if you want to go more into the weeds of all of this. I think it will be great. So let's see, we're almost done with questions. Can high methane SIBO cause restless leg syndrome?
Yeah, it's actually one of the leading causes of restless leg syndrome is SIBO specifically, and very documented in the research that that's absolutely a cause of that. It creates a lot of hypersensitization in nerve endings, and so the nerve plexus that comes into your microbiome originates in your spine. So if you think of that visual of that wrapping around the front of your body back into your spine, and then your spine, it's going down the spinal cord and going into your legs, it completely makes sense why you're pinging that and then pinging into your legs. So almost always when someone comes in and they say, oh, I've got restless leg syndrome, but my gut's totally fine, I'm like, I guarantee you it's SIBO, right? I've never not seen it to where SIBO hasn't been the cause. Not to say
Yeah.
that it doesn't exist, but for me in practice, it's almost always SIBO.
Got it. Got it. In terms of butyrate supplementation, do you have a brand that you recommend? I've been taking the Body Bio one. I don't know if that's a good supplement on from your perspective.
I think is Body Bio the one that's called Butyrin? I always forget which one.
No, it's just either sodium butyrate and they have another one that's calcium, magnesium butyrate, and that's it.
Yeah, I do like sodium butyrate as the option with it. And the 2 brands that I have used are Probutyrate is the one that I've used. Actually, let me look up really quickly. It's so funny, you use these things so often as a practitioner and you kind of forget what the manufacturer is. I love Probutyrate, but it is more expensive. So if you want a less expensive version, Butyrin is great. So Probutyrate is by Tesseract. Their company has been used the most with autism research with supplementing.
Hmm.
So they're like third party tested. I think this is why they're also so expensive, is they've just got a lot of legitimate testing behind them. Allergy Research Group is the one that makes Butyrin. And that one is far less expensive. I'm dosing both of them at 2 capsules 3 times a day. I have gone all the way up to 6 capsules 3 times a day with like a severe ulcerative colitis little boy that I
Oh,
had. So
wow.
yeah, it's like I
Wow.
said, it's very benign. It's not going to cause damage at all. It's only going to benefit you. But long term, I want to grow your butyrate producing bacteria. I don't want to be reliant on butyrate for the rest of your life. So I'm giving that while also giving prebiotics that are going to grow butyrate. And one of my favorite prebiotics for butyrate is from Designs for Health. It's called Paleo RS. It's just paleo resistant starch. So it's much more blood sugar stabilizing starches they're going to give you, but working up to a full scoop twice a day. And then also the sun fiber, which is partially hydrolyzed guar gum.
Got it. So I'm gonna jump into, there's 2 questions in the YouTube, and I want to at least go through those 2. So what's the best way to go for H2S SIBO in terms of overall healing, improving bioflow, and then is it okay or recommended to take artichoke extract and bitters with H2S?
Mm. Yeah, H2S is an interesting one because it responds the quickest, but it definitely needs some specific antidotes that are not the same at all for methane or just straight hydrogen SIBO. So
Yeah.
hydrogen sulfide, and you could easily Google this. I think Paul Ruscio has a free hydrogen sulfide diet. So if you do a hydrogen sulfide diet or basically a low sulfur diet for a week, 80% improvement in hydrogen sulfide SIBO. That's without any supplementation, right? So it's very profound, actually heal SIBO by doing that. But then the botanicals that you're going to be working with are CoQ10, molybdenum, EGCG, which is green tea extract. The reason why CoQ10 and molybdenum is it supports sulfuronidation in the liver, right? So that's the
Mm.
flow aspect, but it's really not bile flow, it's sulfuronidation that we're supporting. Then in terms of a fiber, GOS, galacto-oligosaccharides, the brand name is Bimuno for that. So doing a stick of Bimuno morning and night is really profound for that. What are the other things I usually do for it? Oh, and then don't do garlic, right? Allison will totally mess you up if you have hydrogen sulfide SIBO. Sometimes oregano can work with that, but I actually just like butyrate and then curcumin. So you don't do a lot of antimicrobials. You just do the sulfur support and then
Yeah.
low sulfur in the diet, and it will starve out that infection.
Got it. Would that include also MSM or anything like that?
Some can be useful. It's not my favorite in it. Honestly, molybdenum is my favorite by far.
Just a favorite one. Got it.
Yeah.
Got it.
Yeah.
Maybe we'll just do one more question.
Sure.
How to modulate the gas and your take on possible array of causes.
What was the first part of that?
So how to modulate, I guess, gas.
Okay. Okay.
And yeah,
Gas is a tricky one, right? Gas is fermentation. So I always tell people, there's symptoms that are common and there's symptoms that are normal. Gas is common, not normal. So we should not be having a ton of gas, and we also should not have gas that smells like anything. So if that's happening, fermentation's happening. So then you need to work up, do we have SIBO or do we have LIMO, right? Methanogen overgrowth in the large intestine. You can have sulfur overgrowth too, if I'm being realistic. So that would require breath testing and stool testing to identify that, and then treating that, and that will help the gas to go away. There's no quick fix for bloating and for gas. I wish there was. I would make $1 million if I could sell that supplement. But there's not, because it's happening because of deep compositional changes in dysbiosis. So it's going to take a minute, unfortunately. But I mean, you can use things like artichoke or like ginger, and if you get some relief from that, wonderful. You can use things like chamomile as palliative measures, but it's not going to be as profound as the other things.
got it. Got it. Well, Dr. Lacy, thank you so much for doing this. I think you provided an immense amount of information that's very, very valuable. If people are interested in working with you or, reaching out, what would be the best way to do that?
Totally. So you're going to get most information for me off of my website, and it's super simple. It's just www.drlacey.org, and it's drlacey.org. And then you'll have all of my info there. If you want to email me, it's just info@drlacey.org, and both of those methods are great.
That's amazing. Well, thank you so much again. This is really, really, really great. And you've been I put you in a category of someone who has a bit of an outsider twist in the shoemaker community, but you're also very much part of it. And I always appreciate people who are sort of in that space.
Yeah.
And I look forward to seeing your talk at CIRS, and hopefully we'll get to talk more about this and other things there as well. So thank you again.
Yeah, thanks for having me. Yeah, we're an interesting breed as shoemaker practitioners. And I would say I think all of us really have our strong suits. So I do a free 10-minute intro call with new patients, because if you have something in your case that I think would be benefited from another shoemaker expert, I'm gonna be the first one that says, don't come see me, go see them, because they're absolutely the expert in it. And so yeah, I mean, I definitely think that my expertise is the biome along with that. So if that's something that you're struggling with, I can definitely help. But either way, would love to chat and point you in the right direction.
One quick question. Do you see people outside the state?
I do. So I can see people in California and Nevada. If
No.
you're outside of those states, it's kind of a gray area, but we can do like consultations, sort of a thing. It's just more prescriptions that get challenging for my nurse practitioner. But if that does happen, I've had people like you basically have to fly in and establish in person, and then you can keep managing that way. So there's ways around it, but technically Nevada and California.
Got it. Great. Well, thank you again. And thank you everybody for joining. I hope this was helpful and educational for everyone. And yeah, we'll see each other soon again. I hope you all have a great rest of the day.
Wonderful. Thanks.